and I'm going to do my best to explain it as superficially as possible. Not superficially, but as distilled, I guess I could say. All right, so if you're looking at how much stuff, we've already talked about how much blood flow each kidney receives, right? How much stuff, essentially, as that blood flow goes through the nephron, has to be reabsorbed and secreted. How do we make dilute versus concentrated urine? So on an average day, right, we pull 180 liters of water, go through the glomerulus, and we only pee out 1 to 2 liters, right? Now, what could alter that mechanism? Remember in the disease process we talked about already? Anybody? Diabetes insipidus, yeah, right? We produce a ton of concentrated urine. And why? Because we either don't make enough ADH or our kidneys can't use it, right? So alterations of those mechanisms can alter how much urine we actually produce in the day. But proteins, I'm just going to pull out a couple of highlights. About 2 grams worth of protein go out, and about 0.1 grams come through the urine, right? I will tell you that almost none of that is albumin. Most of the urine, or most of the protein that's secreted in urine is a protein called uromodulin, which is just a protein that is collected in the renal tubules and comes out. Other proteins that are excreted in the urine are like IGs, like immunoglobulins. Most albumin is too large to make it through the glomerular filtration mechanism. So if that changes, then of course we have to discuss what the difference is, like what's going on with the glomerular permeability. Figure out why is protein being lost, all right? Other ones to call out here, we're going to talk a lot about urea and urea recycling today. What is urea? Basically, a protein breakdown product, right? Protein breakdown product, right? And then glucose, if you look at this, a lot of glucose comes into the glomerulus and none should come out, all right? And you don't have to remember these numbers. I'm just showing you. These are examples, okay? I mean, knowing that we shouldn't be, here's a hint for you before you get to your senior semester. You know what doesn't belong in your urine? Blood, protein, or sugar, okay? Simply put, honestly. And if you remember that clinically, and then when you find it and you chase it down and figure out why it's there, you're doing a great job. I'm just going to be honest with you, okay? Because most people will let that go. Most people will see a few red blood cells, a little bit of sugar, a little bit of protein, be like, it's a nothing burger, it's probably because you were exercising. Or was it? And then 2 years later, that same patient comes back, and it turns out that first provider could have intervened. So blood, protein, sugar do not belong in your pee. All right? Fair enough? There we go. All right. Creatinine, on the other hand, 1.6 grams comes in and 1.6 grams go out. How much do we save? 0. Why? Because it is a waste product. It is a proteinaceous waste product that we do not need. It has no physiologic purpose after it's broken down from protein into creatinine, so we get rid of it. It's freely filtered across the glomerulus because we don't want it. What do we talk about? A value that we use creatinine for, that we already talked about, that would estimate something, huh? GFR, right? We use creatinine as one of our parameters to estimate glomerular filtration rate. And why? Because we completely get rid of all of that we make. There's no percentage that we should be holding on to. And if we are, what does that mean? It means we have a reduced creatinine clearance and a reduced glomerular filtration rate. Does that make sense? Just as a bottom line. Waste product, we don't need it. All of it should be peed out or gotten rid of somehow. Okay? Anyway. Basic information. This is extremely basic information. Reabsorption and secretion, tubular reabsorption and secretion. Now remember what we talked about, right? Okay, and this should make hopefully more sense at the end of this day. Think about the milieu of inside the tubule, right? If we're secreting something, what are we doing essentially in most cases? Getting rid of it, right? So if we're secreting, that means we're putting it into the filtrate. If we're reabsorbing it, that means we might need it, we want to hold on to it, we're keeping it in the body. Simple as that. So, but you have to think about it inside the tubule from now on. Okay, does that make sense? Okay. So, transport proteins. We're not going to talk a whole lot about these transport proteins, but essentially what they do is help facilitate reabsorption and secretion, and we'll talk a little bit about them as we go through the process. But a lot of times, you guys have heard of thiazide diuretics, loop diuretics. right? Different kinds of diuretics that act on different parts of the renal tubule, right? So where do you think a loop diuretic would have its effect? The loop of Henle, and how it does so is altering the permeability or the function of some of these transport proteins. Now, again, that's as much as we need to talk about that for now, but just suffice it to say, okay? So tubular secretion, as we just talked about, we're putting it into the filtrate. Putting it into the stuff that is going to become urine. Putting it in the stuff inside the tubule, okay? And this is by no means, of course, a comprehensive list, but just stuff that we need to get rid of, right? Peeing out hydrogen ions, what would that help us do? Maintain our pH balance, regulate our pH balance, right? Getting rid of potassium, just to maintain with that aldosterone. Getting rid of ammonium ion, we don't need ammonium buildup, right? We do not need extra ammonia. Does anybody know what happens, how we start to build up extra ammonia? Does anybody know what disease? Cirrhosis. That's trivial pursuit for now. We'll talk about that in the next block, actually. But as you get liver disease, you start to accumulate more and more ammonia, okay? And you can have what's called hepatic encephalopathy. Creatinine, I just talked about, and then of course we've got to excrete drugs. Renally excreted, renally cleared drugs make their way through the tubule so we can get rid of the product excess that we don't need, that's not biologically active, okay? Tubular reabsorption, opposite. We're keeping the stuff that we need. And just like we talked about in that chart, most of what goes through the kidneys is going to stay with us. Does that make sense? Most of what's filtered is ultimately going to remain. The vast majority, 99% of the water, most of the sodium, most of the chloride, so on and so forth, okay? So the kidneys are, and what changes this regulatory balance? What changes how much the kidneys are excreting or reabsorbing? The body at large. Homeostasis, if you want to leave it at that, right? Do we have too much water on board? We have not enough water on board. Do we need more salt? Do we not have enough salt? Are we hyponatremic? So on and so forth. Again, what is the kidney's main job? To maintain homeostasis, right? So whether we have to up or down regulate, it just depends on the situation, okay? This right here is important to you now, and as we talk about it, most of what we take back, and by we, I mean our kidneys, our tubules. Most of what we take back occurs in the very first part, okay, before we even really get to the loop of Henle, okay? And we get down to the loop of Henle into the distal tubule, we're really talking about taking the last little percentage of sodium, chloride, and water back. That's not it, but that's the majority. Of everything else has already been reabsorbed by the time we get into the descending loop of Henle, okay? And then, yeah, that's what this says, fine-tune the process, if you so, okay? And right here, small proteins, small peptides, really what happens there, being reabsorbed in the proximal convoluted tubule, that is those small immunoglobulins. Have you talked about those at all yet, immunoglobulins? Yes? Okay. IgG, IgA, IgM, yeah. It's basically the Y with the little extra Y, like the heavy chains and the light chains. Light chains is really what we're talking about here. Light chain reabsorption happens there. So, how does the process happen? Either directly through the cell or in between the cells. Simple, but keep it simple. Paracellular, between adjacent cells, transcellular, directly through the cell. Okay? And just to keep your perspective straight, if it is referring to the apical membrane, that is the inside of the tubule where the filtrate is, okay? The basolateral membrane is the outside of the tubule where the interstitial fluid and the capillaries are. So if that makes more sense, let's assume this yellow is P. The inside is the apical membrane. And the outside here where the interstitial fluid and going into the capillary is the basolateral membrane. Okay? And I want to ask, anybody, histology-wise, let's say this is the PCT, which it most certainly is. What are these little guys, these little fingers? Villi and microvilli, right? Remember I just said, and this is a prelude to the actual slide that it has it on, but villi and microvilli, what do they do, basically? Increase surface area, dramatically increase surface area, right? So, because the cells of the PCT have that brush border, the villi and the microvilli, it dramatically increases their surface area, which is why, ultimately, that area of the tubule is responsible for most of the reabsorption that happens. Okay? Anybody tell me where else there's villi and microvilli?
In the gut.
Small intestine, right, where most of our digestion and absorption happens. Just to increase surface area to help with facilitating reabsorption. Easy enough? Yes?
Is that tight junction that we see similar in like mechanism to the tight junction on the blood-brain barrier?
Kinda, yeah. Yeah. It's just basically, so it's not like a leaky barrier, it's not like a fenestration or something like that where stuff can easily flow. Something has to make, water can freely flow through there, but in other places there has to be like actual semporters or uniporters or something to actually move it. But yeah, kind of like that, but not nearly as impermeable, but similar concept, yes, to answer your question easily, all right? Okay, so obligatory versus facultative or as needed water reabsorption. And then most of the water reabsorption that occurs is obligatory. What does that mean? Basically happens by osmosis, right? There's not an active process. It doesn't have to be adjusted. Nothing has to change. Most of our water is going to follow our solutes. I've said many times, water follows salt, right? Salt follows water, right? Water follows salt, right? Water also follows glucose. Water also follows urea and other solutes that help drag it back, okay? So, same thing as we have most of our large osmotic molecules, or not our osmotic molecules, our osmoles, our osmotic substances being reabsorbed like glucose, like sodium, like chloride. Chloride and glucose being the major osmoles in our serum. You guys know what an osmole is? No? An osmole is basically something that can move water with it. Okay? It can create an osmotic balance. Like I said, water follows salt. Salt will drag the water behind it. Glucose, same thing. Will drag the water with it. All right? So obligatory water. As we're reabsorbing the sodium, as we're reabsorbing glucose, water is just kind of coming behind it via osmosis. Okay? Make sense now? Better? And the PCT is where most of it happens, like I've talked about. Later, when we talk about ADH. Now, obligatory versus facultative. What does facultative mean? Adaptable. Let's think about it. Think about it as facilitated by, right? What could facilitate increased water reabsorption later on that we talk about over and over again?
Alcohol.
Anti-diuretic hormone, right? So most of the facultative, most of the obligatory reabsorption happens well before the distal collecting duct and the distal tubule and the collecting duct, right? So if our body recognizes we don't have enough fluid volume for whatever reason, what happens? We secrete anti-diuretic hormone, and then we have facultative water reabsorption later on in the nephron. Does that make sense? Now, at least, we're going to talk about it, trust me. But, got it? So most of our water reabsorption just happens by osmosis. And when we need more water, we have a mechanism to keep more water. Does that sound better? Because that's exactly what I just said. Let's keep it simple for right now, okay? That's all we need to talk about right now, okay? All right. Glucose-urea, just a real quick clinical correlation. Diabetes, right? Say somebody has an extremely high sugar, which most diabetics do, okay? So that means a ton of that sugar is being filtered in through the glomerulus. Way more than the cells in the glomerulus can handle, okay? So what does that mean? It means a lot of glucose is staying in the filtrate because it just can't, it overwhelms the capability to be reabsorbed, right? Still with me? So we have basically a syrupy urine, right? And so what did I just say? Obligatory water reabsorption, what happens? Water follows these solutes. Water stays with the glucose instead of being reabsorbed, and it is excreted in the urine. So we have a very dilute urine with a lot of glucose in it, which is one of our ways that we discovered diabetes, right? And do you remember what are the three polys? One of them is polyuria, which we just talked about. And if you're peeing a lot of your water, you're going to be dehydrated and thirsty, which then leads to polydipsia, extreme thirst, right? Does that make sense? So that's just sort of how this sort of osmotic gradient is affected by something like diabetes. Okay? Easy-ish? Does that make sense? Okay. Let's talk about tube histology, one of my favorite things. I love cellular histology. I know. Okay. So, in the PCT, this is the big part right here, the microvilli. Okay? And exactly the reason what we just said. Secretion, or increased surface area for reabsorption. We're keeping more stuff. Okay? The descending scripples, don't spend too much. I'm going to point out for you the thing that I find most important on this slide. Okay? There you go. The rest of it is kind of whatever. I'm not going to lie. I really don't care about the histology. Yes?
I just had a question on the three. Is there one that predominantly will override the other one between the sodium chloride and glucose? Is there one that water will follow more of the three?
Okay. When you get to like ClinLab and you learn the formula for serum osmolality formula is 2 times the sodium, and then it's glucose divided by 18 or something like that, right? So the prime mover of your sodium, because your average sodium concentration in the body is 135 to 145, right? 2 times that creates about 290, right? 280, 290, right? Your normal your normal plasma osmolality is somewhere like 298, 299, right? So the vast majority of your osmolality in your serum is going to come from sodium. So sodium is a prime driver of that. And you get to a situation where you have so much an overwhelming amount of glucose, then you get to the situation I was talking about. So outside of like a diabetes or a severe hyperglycemia, it's the answer to that question is sodium. Yeah. Okay. So this now, on the other hand, is important when you go to histology. Principal cells and intercalated cells in the DCT and the collecting duct. All right. The reason why those are important, the principal cells are where. Does anybody remember me talking about aquaporin channels being created from ADH? This is where those channels are going to be created within the principal cells. Okay. The intercalated cells have to do with base or acid-base regulation and excretion. Okay, so they're all important in the kind of the final processing of our urine, our filtrate into the urine, whether we're going to have dilute or concentrated urine, whether it's going to be more acidic or more basic. Again, based on fluid balance and acid-base balance. Okay, and we're going to have it. We have slides on those too. I'm just telling you what they mean right now. Okay, everybody's sort of with me so far. This is a lot for 8 in the morning, I realize. You guys good? All right. So, here we go. Like I said, it's one of those weird backwards nephron drawings. We thought we're going to go down the PCT, right? Down into the descending loop of Henle. Down the hairpin turn, up the thin ascending. Then there's a thick ascending limb into the distal convoluted tubule, and then ultimately into the collecting duct. Okay? So we're going to go piece by piece, essentially. That's why I just did that. All right? So let me just give you this, without reading all the words on this slide. Basically, 2 main drivers are going to be responsible for tubular secretion and reabsorption. And it's going to be an electrical gradient and an osmotic gradient. We're not going to focus in here very much at all on the electrochemical gradient because it's negligible in most cases, but what really drives these solutes back and forth is an osmotic gradient. Okay? This literally the process of osmosis. And what did I just say, honestly? Most of it is I've already explained most of it in the PCT, where most of our sodium chloride and glucose are reabsorbed, most of our water just follows it. That is the overwhelming drive to move these things back and forth is an osmotic gradient. Now, before I go any further, does everybody understand? Does anybody not understand conceptually what an osmotic gradient is? Okay, good. That's great. I'm glad. So let's go. What the hell was that? So this drawing in that last slide is meant to also make you understand that this is none of these processes. We're going to talk about them individual as if it's just one thing happening one step at a time, right? All of this is happening simultaneously and constantly because as some of the filtrate makes its way down the tubule, what's happening behind it? More blood. It's just constantly. So this is always a constant process. But we're going to break it down as if it's just happening step by step so we can sort of understand it. But does that make sense? The reason why that's important that it's constantly happening is because that electrochemical gradient and that osmotic gradient have to be there constantly, or else there's going to be no net movement of anything, right? So this constant flow of stuff sort of helps contribute to maintaining that gradient. Does that make sense? You all just told me you know what an osmotic gradient is, so does that make sense? Okay. So let's talk about the PCT. So, I already said this, right? All of our glucose, most of our bicarb, right? Bicarbonate, sodium bicarb are the main buffer in the system to buffer acid, right? That will become more important later if you talk about renal tubular acidosis. We have renal tubular dysfunction and it can't absorb that bicarb. Then you have acid-base imbalances. Okay? Our urea, we'll talk about this, why urea recycling is important, but in a nutshell, it's because it contributes to an osmotic gradient in a dehydrated state, okay? And then so on and so forth, all right? But look, I mean, just looking at this list in sum total, right? In sum total. Most of the shit is reabsorbed before we even get to the Lugol family, right? So a lot of the work is already done. So, what does this mean? Sodium transported out of the tubule and into the interstitial fluid. What is another term for that? Tubular reabsorption, right? Tubular reabsorption. Keeping stuff that we need. Glucose, sodium, we need those things. We're keeping them, all right? Chloride follows generally. It doesn't usually come across as sodium chloride, right? It's sodium and chloride, but sodium is positive, chloride is negative. We reabsorb about equal amounts of those. What does that do to the net charge? It's about even. This is why I said a lot of times the electrochemical gradient really doesn't contribute a whole lot unless we have a sodium chloride imbalance, which we can in different states of sodium, hyponatremia, hypernatremia. But suffice it to say, that's why I said the osmotic gradient has a much greater role in this process, okay? So, to that point, movement of sodium chloride into the interstitium creates an osmotic balance. So, again, by the process of osmosis, if we have more sodium and chloride now in the interstitial fluid and the capillary blood, which way is the water going to go? Which way is the water essentially obliged to go? To follow it, right? Which is why most of our water reabsorption happens there. Does that make sense? You guys? Yes? Okay. And these are aquaporin 1 channels. These are the ones that always exist. Okay? The aquaporin 2 channels we'll talk about later with ADH. Okay? So these are the ones that are always there to help us reabsorb water and reabsorb sodium. Right? Aldosterone has a lot of its effect on aquaporin 1 channels. Right? And this process here, which we are not going to get into, is just called solvent drag. A lot of times osmosis will bring stuff, a lot of times in a weird sort of way, water will actually bring stuff with it through solvent drag. These things are not a huge contributor to osmolality, calcium and potassium. So just take that as for what it's worth, okay? That's a lot, and we don't need to talk about it. Does that make sense to everybody? Okay. And so for all you picture folks, there you go. So if we're going, in this case, through a sim porter that, you don't need to know what a sim porter, unit porter, and porter is. You can probably unpack it, right? But if it's going through a thing directly through the cell, what process is that? Transcytosis, right? Right? If it was going through between them, what was it called? Huh? Parasite. Yeah. You got it. There you go. Parasites. All right, good. Okay. 5-minute breath. Here we go. Keep going. All right. Proximal convoluted tubule, urea. Urea recycling. This is going to be the first part of urea recycling. And there's several slides on it, but let me just give you the gist. Okay, so just follow me here for a second. Essentially, urea recycling contributes to maintaining an osmotic gradient when we are in low volume state. All right. So what does that mean? It means that urea is a proteinaceous breakdown product. We don't need urea per se. It doesn't have a whole lot of use other than this. But as it makes its way through the tubules, if we have a low water situation where we need to increase our water, urea will be recycled back into the renal interstitium in the medulla to create a high osmotic gradient. That water will then go in, will keep water, water will follow the urea into the interstitium, right? Because if we're in a low volume state, where do we need our water to be? Inside of us, right? Not in the urinary filtrate. So as the urea is being recycled and reabsorbed, water is kind of following it. So we're holding on to water. That process is facilitated by ADH. So bottom line, if you want to think about urea recycling, as we get more and more dehydrated, we have more ADH, more urea is kept in the interstitial fluid to help drag more water behind it, to help keep water in the system. That's urea recycling in a nutshell. And I have a whole slide on it that we'll go over, but just so you know what I'm talking about as we progress through this slide. Does that sort of make sense? A little bit, I know. Urea recycling stuff, but I just want to give you a prelude to it. So, let's go through it. Here we go. Urea, about 50% of the urea is resorbed in the interstitium, right, if we're doing urea recycling, okay? Which means 50% is left. That's what this slide says. 50% comes out, 50% stays in. Easy enough. I'm trying to give you the bottom line up front on this slide right here, okay? When you go to the thick ascending limb, like so we're going down, we're going back up now, okay? We're going into the distal convoluted tubule. Urea can't come back in. Urea is impermeable, right? So in general, that's the way it works, right? We don't need to keep urea if we're not in a low volume state. We just need to get rid of it, right? We get rid of urea, okay? If we get to the distal part of the DCT and then the initial part of the collecting duct and we are recognizing low volume, then ADH kicks in and we start to recycle and pull some of that urea back into the interstitium. Does that make sense a little bit? So check this out. Here we go. So we're in the PCT here. We have 50% of our urea left. In normal situations, it just kind of stays in. Like the red arrows are usually when we are dehydrated. So typically we'll get rid of much more urea than this if we're not holding on to it. Now, because this slide shows you what happens when we are in a dehydrated state, right? So this slide shows you urea recycling under the influence of ADH. Okay, so everybody got it? I wish there was an easier way to explain this. I did not. So if we need to maintain a higher osmotic gradient, right? So we are going to hold on to more urea, meaning that some more is resorbed out here, and 55% more is reabsorbed here, and then put back in the situation here. So this, I don't want to keep drawing on the slide, but this becomes a loop of us recycling urea and helping to pull water with the urea as we pull it back out into the interstitium, right? This obviously is the tubule, this is the interstitium, so we're trying to reabsorb more water. As we reabsorb larger and larger amounts of urea, we're able to pull more water back into it, into the interstitium, and keep more water in the system. Does that make sense? I know it's several mouthfuls, but does it make sense? Yeah. Yes, exactly. That's what this red arrow is, right? So as it's this part, this thick part right here is impermeable to urea, but this part down here, the thin loop and the hairpin turn is not. So it can be pulled out of here, put back in here, and essentially reused over and over again. Does that make sense, everybody? Yeah.
So since there isn't like one spot that just does all this at once, is this just happening like redundantly because of how fast everything?
Yes. This is happening throughout, I mean, again, we're looking at a nephron, right? So yeah, this is happening throughout the entirety of the kidney. So we're able to produce and hold on to more water. Right. What's that? I thought you had a question, sorry. Oh, you got it.
So this would create like a back pressure?
Not necessarily a back pressure per se, as far as like a pressure gradient. I mean, it just really creates that osmotic gradient, right? It help that osmotic pull. And it also at the same time, we haven't gotten to the rest of ADH. It'll open up those aquaporin 2 channels, so we're also pulling out other water. So it's not really necessarily a pressure gradient as much as it is as maintaining the osmotic gradient in the loss of solutes in water. I don't know if that answers your question or not. Okay. But it's not really a back pressure, no. It's not like I mean, I guess if you're talking about a backwards osmotic, it's not even really a backwards osmotic pressure, because normally, if we are not dehydrated, we have a sufficient osmotic gradient in the renal medulla. We're keeping the urea in a state of low solute, low volume in order to maintain that osmotic gradient. So it's maintaining the pressure gradient more so than it is creating alteration of it. Insufficient sufficient concentration, yes. So again, the other part of that is like it's like the blood urea nitrogen divided by something. I can't remember that off the top of my head, but normally it's negligible, but in high concentration it can have a slight effect. Yeah.
What's the urea doing in the efferent arterial? Like, it's going back into the blood supply there?
It has to be if it's in the amount. So that's a good question. When you're sufficiently dehydrated, or when you get dehydrated, the first parameter that starts to go up is your blood urea nitrogen. Your BUN starts to go up. So we will accumulate urea to facilitate urea recycling as the kidney is functioning. So your BUN goes up, but your creatinine still is excreted completely. When you start to see like intrinsic renal disease, like nothing is working in the kidneys anymore, then you'll start the creatinine start to rise as well. But yes, some is going back into the bloodstream, right? Which is why when you get to start looking at clinical, like clin lab, why does BUN go up? This is one of the reasons why BUN goes up when you're dehydrated, because we're holding on to it to recycle it in order to maintain more water. Does that make sense? All right. That's the hard part. Good job. What questions do you have so far? So many. Is anything just completely not coming out as just complete Greek? All right, what's up?
So on the last slide, it says the thick portion of the loop of Henle is impermeable. So
Right.
how does it get? Is that just the ascending portion?
Yeah,
Once it gets
the
to
thick
decent-
ascending portion. So there's no thick. There is technically a little bit of a thick. This is mostly proximal convoluted tubule, but yeah, thick ascending portion. So it can't get out. So it is able to basically loop around and be recycled again.
So up at the 30%.
When you get to about right here, this becomes. I know this is a rudimentary rendering, like it does. It's not all twisty, but this is representing the distal convoluted tubule.
Oh, okay.
Yeah.
That makes sense.
This is like a very, very simplified version of the nephron, just to show you what's happening where. But yeah, when you get to that distal part of the distal convoluted tubule, which is a mouthful, and the initial part of the collecting duct, then it can be reabsorbed.
Okay.
Okay. Any other questions? Sure. Are you chat GPTing something to verify? What? What's that? Oh, yeah. You're gonna be fun in phase 2. I wish you were my student in phase 2. I would love having you in phase 2. I'm just kidding, man. I'd be doing the same thing if I had chat GPT back in the day. We used to have a bullshit flag. We used to have like literally like a yellow flag. We were just like, you're making that shit up. Yeah. And the instructors who would admit it were like, yeah, I am. So anyway, urea recycling. What's the point of it? Just give me the gist. What's the point of it?
Hold on to water.
Hold on to water. That is the gist of it. Hold on to water in a low volume state. Now again, with all of that outside of a low volume state doesn't happen. Urea recycling is negligible if we don't need to increase facultative water reabsorption, right? If we're good, then we're good. When we get to the need of secreting more ADH because we recognize low volume and we need more volume, that's when that becomes a significant factor, okay? Does that make sense to everybody? So when, right now, y'all, unless you're really dehydrated, that shit's not happening, which is why your BUN is normal, right? All right. What else happens in the PCT? Because we're still there. We secrete phosphate from parathyroid hormone. We get rid of phosphate. Phosphate, if you just remember this, phosphate and calcium in the system are typically antagonistic. So if calcium's going up, phosphate's going down, and vice versa, in general, okay? So what is parathyroid hormone trying to do? Raise our calcium, which is why we're getting rid of phosphate. Like I said, they're kind of antagonistic. So if one's going to go up, one's going to go down. We're getting rid of phosphate. We want to keep calcium. So simulates calcitriol. Right? What is calcitriol? The hormone that the kidneys make, right? The lipid soluble hormone. Yes. Okay? And that helps us reabsorb more calcium. And also, we reabsorb more calcium in the DCT. Okay, so what is the net effect? Parathyroid hormone just in the kidney. We're not talking about the bones and all other shit. Just in the kidney. We're keeping more calcium. We're getting rid of phosphate. Okay? And there's that for all you visual learners. But again, this is really what we're focused on here. Just the kidney, not the rest of it. Not now. All of that is the proximal convoluted tubule. That's where I said most of the stuff happens. That's most of the stuff. All right? More reabsorption in the loop of Henle, okay? Basically a lot more water, but only in the descending portion, and that's going to become important here in just a minute. We talk about concentrating the urine. So a significant amount of the remaining stuff is reabsorbed before we get to the ascending limb, right? That's why the DCT is mostly water, sodium, and then some hydrogen reabsorption. And the collecting duct, honestly, is mostly water. Mostly has to do with water, which is why in our textbooks, we don't refer to it as part of the nephron. Right? So, this is a lot. Let me break it down for you. The descending limb is selectively permeable to water, also permeable to solutes. All right? So, as we go down, solutes are actually being reabsorbed into the filtrate, or secreted into the filtrate, let me use the correct terminology. All right? And so as we go down the descending limb, the water is coming out, solutes are going in, we're becoming progressively more concentrated as we go down. All right? Let me skip ahead just to show you what I'm talking about. So as this is the descending limb right here, this one's going down. I know it just shows urea, but also sodium and chloride are going in. So as we go down, as we're losing water, we're becoming stepwise more and more concentrated, right? These numbers represent osmolality. Does that make sense? As we're going down the descending loop, We're losing water, gaining solute. It's getting what? More concentrated. That's it. That's the roll up of it. Okay?
Showing only urea in the diagram.
It's only showing
That's-
urea on the
but it's not,
diagram,
right?
but again, right here,
It's
if you look at
extra
this,
sodium chloride.
yeah, right here, look at that little bullet right there. So I didn't find a diagram that had both of them. I could draw them in next time, but I mean, I'm being serious. Like sometimes it's easier for visual learners to see it exactly the way it is. But does that make sense? So it's not just urea, even though that's what the picture shows. Okay. And again, does that make sense? As you're losing water and gaining stuff, it gets more and more concentrated, right? So as we're going down, it's getting more and more concentrated. Yes? Okay. And that's essentially, all of the words on this slide, that's essentially is what it's saying. We're gaining osmolality as we go down the descending loop, okay? Now we go to the ascending limb, right? So we have a hairpin turn, we have a thin portion, then it goes into a thick portion, right? We saw that already on the urea diagram. The thin portion becomes now impermeable to water, okay? Okay? Solutes can still move, but think of the ascending limb, both the thick and thin portion, as impermeable to water. So, if we are reabsorbing solutes, so we're bringing solutes out of the filtrate and back into the blood, but the amount of water that is in the filtrate stays the same because it can't get out, what happens as we go up the loop? It gets more diluted, right? Does that make sense? And that's exactly what it is. On this side here, on this side, water can't get out, but solutes can. So as we're taking stuff out, the amount of water stays the same. We get more and more diluted. Meaning that the most concentrated urine is down there at the hairpin turn, where it turns. Okay? Most concentrated. And then we have least concentrated on this side. Okay? And again, just think back to what I've already said. What's going to happen now in the distal convoluted tubule and the collecting duct? Mostly water reabsorption. Right, so now we have some dilute urine, and mostly we're going to reabsorb some water. Okay? And here we go. A little bit of sodium, a little bit of chloride, not much, but it's going to pick up a decent amount of what's left of the water. All right? So we've concentrated our urine, we've diluted it, now we're concentrating again before we get rid of it. Okay? And we get to the late portion of the distal convoluted tubule, which is right before the collecting duct. Almost everything is already done. Most of it's been done in the proximal tubule, and a significant amount of water and chloride and sodium reabsorption in the loop. And now we're focusing mostly on regaining our water that we need. Okay? And what do you think is going to have its effect in the distal tubule, the late distal tubule, and the collecting duct that's going to help us reabsorb more water if we need it? ADH, right? And aldosterone. Very good. All right. Back to these guys. Our principal cells and our intercalated cells. Principal cells. Okay, there are guys that have their effect for ADH. Okay. And what is the feedback loop that's helping us know and telling the kidneys that we need more ADH, we need more water reabsorption, osmoreceptors throughout the body, pressure receptors? Do we have enough volume? Do we not have enough volume? Okay. Giving us that feedback, secreting ADH, secreting aldosterone, turning on renin-angiotensin-aldosterone system if we need it. That's the feedback that's giving us being the nephrons, the information to say either the water is sufficient, we can pee out normal urine, or we need to concentrate it, or we need to dilute it. Fair enough. Okay? Just feedback from the system saying there's either enough water, too much, or not enough. Where are we at? That's all. And in the distal tubule, let me break this slide down for you. Okay. In the distal tubule, since we need, we have to create some water. Some water has to be excreted. Okay. If we need to reabsorb more water, we create facultative reabsorption via aquaporin 2 channels with this little guy right here. Okay. So that means we're not, basically what I'm trying to say is as we're going down the distal tubule and the collecting duct, we're not just sucking out all of the water. We have to secrete some water. We produce fluid urine, right? Whether or not we have to suck out more of that water or leave it in, it depends on the presence or absence of ADH, right? Antidiuretic hormone. Yes?
Is ADH like a concentration base, or is it like it's either in the cells or it's not?
That's a tough one to answer straight out. There's always a little bit of ADH in the system, right? But it's increased or decreased. Aquaporin 2 channels, unless you're a complete homeostasis in general, are going to not be there. So the effect of ADH, the way to think about it? Yes. Just think about it as an all or none situation. That's the easiest way to think about it. Let me not confuse the issue, right? Either ADH is present or it's not. That's the way we're going to think about it, all right? There you go. Let me just stop myself before I go on down on some kind of weird tangent that we don't need to go on, all right? Does that make sense for right now? Okay, good. Because essentially that's how these slides are built. Either it's present or it's absent. And that's the best way to think about it as you're just learning it. So just leave it at that. Either we have ADH and then we have aquaporin 2 channels, or we don't. One or the other. Okay? Fair enough? Okay. So, in that, if we do have ADH, thinking about it that way, those principal cells inside them will create an aquaporin 2 channel, a proteinaceous channel, essentially allowing us to reabsorb water. Remember, the ADH just reabsorbs water. It doesn't bring solutes with it, right? What does bring solutes with it? Which its sister, basically? Aldosterone. Okay. And so, the more ADH, the more aquaporin 2 channels. Is it really on-off? No, but for our purposes, yes. Okay? And then what happens as we have more channels to absorb more water? What ultimately happens to the end product? It becomes more and more concentrated. When we have ADH, we produce less physical amount of more concentrated urine, right? Because we need the water. Does that make sense? We've talked about ADH a lot now. This is what it actually does. So does it kind of make sense to you? Right? Because we're just sucking more water in, right? All right, I can feel it. We're going to stop talking about ADH right now and take a break. We're going to come back and we have a few more slides. And then we're going to be done with renal. I told you.
On that baby. That's distorted. I have no use. I don't know. Try it. The boss carries no. Front door. Security guard.
It's like a psychological question. How it backs
I mean, really, that's, I mean, you should probably not really. ADH, well, aquaportin can be effective for ADH.
Got lettuce wrap today.
Staying straight.
Oh, nice. Little bow there. They fix that? What's up with that? That one looks crystal.
You can see where it broke.
Just barely though. These kid bows, man. This was just yesterday?
Nothing in that wrist. No, they're there right now.
Nothing in the wrist? Just because it's all cartilage or what? Oh, because it's not. Yeah, because it's just so young. It's not like ossified yet. Huh?
It's crazy.
That's crazy. Just looks like the band is just kind of floating out there.
The longer loops of that way, pause it with
Yeah, as my like 1.5-year-old like climbs all over the couch or whatever, and he just like gets himself off the back and like lands upside down on his head.
Yeah.
And he like lands and like if I landed like that from the height equivalent to his height, like my shoulder would be out. I'd have a broken. I'd have something, and he just laughs, goes back around and yeah. like, man.
You ever jump and like hits and just like looks at you because you know it hurt? It's like, yeah, I know that one hurt.
Oh yeah. He's real top heavy, big old fat head.
You ever put their hands over their head?
That's my test to see if he's growing okay. See when I can get his hands and touch him over top. He now claps above his head when he gets upset when he's like tries to move, and then you set up in front of him, he'll go. Just barely making contact. Just
My oldest has a big head. When he was a baby, his hands were like this, not even close.
Probably, I don't know. But it probably has to do with urinary concentration. The impermeability of water. It's like splitting of the cell. Yeah. I think it's just
Oh yeah? You ride stand up plane or on plane? Right on I don't know. When I text, if I'm sitting in my seat, I'm buckled in and I'm waiting for I'm taxiing, and I text my wife before I turn on airplane mode, I'm like, all right, I'm on the plane, about to take off. I'm just wrong. I'm just using it. And that's why you ride on a bus, not in a bus. You don't have a seatbelt. Hey, I'm coming. I'm gonna scooter. Be there in a minute. I'm gonna live scooter. What? No, I'm buckled in. Strapped in the scooter. So you ride in the seat. You ride on. I'm strapped in. So you're in. Right. I'm coming down and riding my snowboard. Okay, guys. That's cool. You guys look all If you're on this one free you're on. You're on. Yeah, it's like a taco. It's a protein. Protein is like round inside. $1 go far. Sometimes that's like, yeah, sometimes
Yeah.
literally it has to be over 40. Or like, you know, that like,
Alright, you guys.
like you have a 6 on your chest. You're not gonna see anything.
Who's this trainer on? Alright, so this last little bit is again, another bullet about urea recycling. Alright? As more water is resorbed, it says osmotic balance is created in the distal collecting duct. So we need to maintain that osmotic balance, especially in a low volume, low solute environment. And so that's when we start pulling the urea out for urea recycling, okay, in the presence of antidiuretic hormone. So if you go back to that urea recycling diagram, those red arrows where the urea is coming back out are only happening when we have ADH. Let me show you what I'm talking about. Just stick with me. I know, it's a lot. So this right here, these red arrows, all of this, let me get rid of this phrase. So all of this, that's only happening, that reabsorption of extra urea in the bottom is only happening when we have the ADH, right? If we didn't need it, if we had sufficient fluid volume, we wouldn't recycle that urea back up. So the percentages would be off, and the percentage that we excrete would be much greater because we don't need to keep the urea, which is a waste product, to maintain an osmotic gradient. We need to just get rid of it like we normally do. Does that make sense? Right? So then, last little bit, this is maximum ADH, we can drop down to 400, like severe oliguria, right? We can really hold on to as much water as possible, 400 milliliters daily versus a liter, 2 liters daily, right? With maximum ADH secretion. And then as we get rid of ADH, meaning we don't need it anymore, our volume is stabilized, we gain more volume by whatever means, drink water, right? The aquaporin 2 channels, they kind of disappear, and then we return to a more dilute urine. So, in summary of what I just said, as our volume returns to normal, our need for ADH drops, the aquaporin 2 channels go away, and the filtrate that goes through becomes more dilute, and we go to a regular, normal concentration of urine. Does that make sense? Right? ADH is present, we have concentrated urine, ADH goes away, our urine becomes more dilute. Fair enough? Okay? And then this is what, I think somebody asked me about the aquaporin 1 channels. Okay, the aquaporin 1 channels, they're always present. Okay? ADH and aldosterone have a synergistic effect. They both help us hold on to water, but the aquaporin 2 and the ADH are only present when we have sufficient need for them. Does that make sense? And here's a picture for those of you who like them. Okay. And principal cells in aldosterone, like I just said, they have a synergistic effect. So we will hold on to sodium, because what does sodium do? It drags the water through as well. Okay? Generally, this is why I say they have a synergistic effect. Because when we have a sufficiently low volume to kick on ADH, what else is on generally? The RAS, in order to preserve intravascular volume. So if you have ADH, generally you also have aldosterone kicking in as well. Okay? Okay, those are the principal cells in ADH. Does that stuff make enough sense for now? Any questions about it? All right? I mean, when you really break it down, it was the last bit we just talked about in the distal collecting duct and the distal tubule and the collecting duct. We have low volume, we need more volume, ADH is produced, we already know that process. What does ADH do? It creates aquaporin 2 channels in the principal cells in order to keep more water in the system. When we have enough water in the system, those channels go away and everything goes back to normal. That is the summary of those slides we just did. Does that sound fair to you guys? Okay. Yeah. Okay. One more time. Sorry, deaf. Hyperkalemia. Oh, we kick out aldosterone in hyperkalemia too, because what's the other function of aldosterone? To secrete that get rid of that potassium. So if we're hyperkalemic, we'll have aldosterone as well. So it's just two different stimuli for aldosterone secretion. Okay, good question. Sorry, I kind of blew over that one. Intercalated cells, so the other type of cells in the same area. We're still in the DCT, okay? These ones will help us with acid-base balance, okay? Easy way to remember, type A or alpha cells help us when we have too much acid, all right? What do you think happens when we have too much acid? We turn on, we get rid of acid, exactly, we get rid of acid. We secrete more hydrogen ions, we keep more bicarb, and we keep more potassium, okay? The reason why we keep more potassium is that way we can keep switching up potassium. Remember, a long time ago we talked about it. If you have too much hydrogen, what happens? It'll try to shift it intracellularly in order to kick out potassium. So if we have that potassium, it'll help us with that mechanism. Type B, base excess. We have too much base. What do we got to do? Keep acid and get rid of base. What? What's up? What are you laughing at? We're laughing at me. What are you laughing at? You think you're better than
Singing all about that bass. All about that bass, no trust.
Nice. Well done. I just see you two start cracking up. I got to know what's going on. Right? There you go. That's the way you guys are going to remember it now. Oh, we have that song. But does this make sense? Because what is acid in the body? Hydrogen. What is base in the body? Bicarb. Right? If you have too much acid, get rid of acid, keep bicarb. If you have too much base, get rid of base, keep acid. Fairly simple, right? Yeah? All right. Base. Atrial natriuretic peptide. Okay. This one is, you can think about this one. Somebody was asking me, what is antagonistic with ADH? You can sort of think of this as antagonistic with ADH. Not necessarily, but it does the opposite thing, right? It inhibits the reabsorption of sodium in water, and why? What is the stimuli for A&P production or secretion? Increased stretch, increased pressure, like recognition of too much volume. So now we're allowed to get rid of water, okay? So instead of all of that mechanism to keep it, we're going to get rid of it, all right? So it inhibits the RAS. It inhibits sodium retention and water retention. So we reduce blood volume, okay? Okay? So, again, dilution and concentration, we've kind of gone through it. This slide is a little bit redundant. But essentially, body fluid volume Like overall, whether we have, if we're hypervolemic and we're third spacing, we have edema, or if we're hypovolemic, body fluid volume, what is happening there is mostly due to kidney excretion or retention. Mostly, all right, not entirely. Right? So, regulation of plasma osmolarity and volume. So, concentration and the physical volume of plasma is regulated by all the mechanisms we just went through. This is essentially going through and a roll-up of everything we just did. Okay. The PCT reabsorbs most of our stuff. Then we get to the descending loop with Henle, and we concentrate. So we go down, we concentrate. As we go back up, we dilute. And then we go around the DCT and the collecting duct. We get our final bit of water homeostasis, whether it's with ADH or without. And then at that point, we have our final product, which is urine. Okay? Important concept. Hopefully this is clear as a bell by now. If we don't have ADH, we have dilute urine, and if we do, we have more concentrated. Straightforward, right? At this point, hopefully. And if you like diagrams with lots of numbers and words, there you go. But ultimately, on this side over here, like what happens if we have way too much volume, or what happens if we can't use or can't make ADH? We get tons of dilute urine. What happens if we do have ADH and it does work properly and we are dehydrated? We get a little bit of highly concentrated urine. Simple, right? The process isn't simple, but the result is fairly simple, right? And we've talked about ADH so much in so many different, like basically in every block so far. So does this make sense to y'all? Okay. All right, now here, let's turn the volume down. What do you say? Let's talk about easy stuff like sticking a piece of paper in a jar of urine. Okay. Assessment of renal function. Okay, easy stuff. Urinalysis, baseline. Okay. Urinalysis is how we find most kidney disease, honestly. And then we find it when we're not looking for it. Like I said, you'll see. What are the 30 things that don't belong in urine? Blood, sugar, and protein. That's right. And so if we find some of those on a urinalysis, which is often how we find them, we chase it down, fill it out, because those are regular parameters. Blood cells, protein, glucose, and other things, all right? Most of the time, it's just a random clean catch for some reason. We just get a urinalysis, and then we see something that's off on it, and we chase it down, all right? That's a big thing. It's one of my soapboxes from here throughout the entire course, is that if you see something wrong in a urinalysis, repeat it, and see if you get the same result or a different result, and then figure out which one is correct, all right? Because just dismissing something like proteinuria or minor hematuria or minor glycosuria can really set that patient up for something. Especially, we always think, here's my soapbox that I go off of. We always think about, the practice setting that we practice in, right, where you kind of own your patients, you can make them come back to you, more or less. You know what I mean? Think about practicing, for those of you who are, National Guard or Reserve, who are going to go back and practice in the civilian side. That encounter with that patient may be the only time you're going to see that patient. If you don't have an impactful encounter with them, if you just let their lab go, then you might never see them again. And you might have a hand in their negative outcome way later on down the line. So make sure that you do your diligence and chase down small things like an abnormality on a urinalysis, which is the most routine of routine tests, right? You know what I mean? So anyway, that's my little soapbox. We don't need to remember this. I'm not going to ask you parameters on this. This is what Clin Lab is for, but just as this is the parameter, these are what we test for when we do a dipstick urinalysis. The reason to go on the protein train a little bit more, does anybody know what protein is mostly detected by a dipstick urine? Yes.
So I just have a question.
Okay, what's up?
So you said you will repeat the test.
Yeah.
The test result is kind of a little odd.
Uh-huh.
Do you repeat the same test or you add extra?
It depends on what parameter is. It depends on the patient. If you don't do anything else except get another urinalysis to see if it's positive or negative, then that's good enough. Now, depending on the patient, I'm not gonna take you guys down that path right now. There's a whole host of other things you could get necessarily, but for right now, let's just say, if you don't remember anything else, don't let it go. Follow it up with something. You know what I mean? Okay. And anyway, protein. Anybody know which one is on there? Albumin. Huh? No, urobilinogen is not what I was talking. Uromodulin was the protein I was talking about. Uromodulin, not to go again down another rabbit hole. Uromodulin is a protein that catches stuff in the tubules. Ultimately, it can become casts or stones. Doesn't matter. Urobilinogen is a breakdown product of bile. We're going to actually talk about that in the urobilinogen process in the digestive block. Albumin is the most common protein. What's picked up on a dipstick urine. But the problem with that is, by the time dipstick positivity happens, that patient's already spilling a ton of albumin, which is why we now have a test called microalbuminuria for diabetics to screen at a much lower level. Anyway, so if you see protein positivity on a dipstick urinalysis, again, just to reinforce, that patient is spilling a lot of albumin, so you got to figure out why that's happening. All right. Let's see. Nitrite, leukocyte esterase, those are markers of infection, just so you know what this stuff is. Bilirubin, urobilinogen, like I said, we're going to talk about that process. We know what blood is. Ketones, what are those? Anyway? Anaerobic metabolism, fat, right? You're in everybody, ketone diet. So markers of starvation or anaerobic metabolism, glucose and pH, we know what that is, okay? So, serum markers now. And again, I'm not going to, just so you guys know, you don't have to know these numbers on any exam in IPAP because you're going to get normal values. So if anybody asks you normal values, let me know, I'll talk to you. But if you have a test, you should get normal values because that's what the pants gives you is normal values. Blood urea nitrogen. That is the top number. And the bottom number is serum creatinine. You'll also have what's called a BUN to creatinine ratio. We're not going to get into the ratio. Suffice it to say that if that is altered, then that's a marker of either pre-renal disease, meaning like dehydration, or intrinsic renal disease, like the actual kidney is sick or dying. Okay? Blood urea nitrogen. If you are dehydrated, this number goes up. Does anybody have an idea why? Because it's being recycled in the ridiculous amount of slides that we just covered for urea recycling. That is exactly right. When you are dehydrated, you will see your BUN number go up because your body is holding on to urea for recycling to do all the things we just talked about. When you start to see creatinine go up, that means the kidney itself is failing. Okay? Inulin. Remember me talking about that thing that you can actually directly measure your glomerular filtration rate, so it's not an eGFR, it is a true GFR. Inulin is the thing that you inject to do it. Don't spend any time on the inulin slide. That's just what it is, okay? And this, like I said, this is why it's continuous IV while the patient's peeing. So it's literally like a real-time urinalysis. So it's an invasive process. So it's only done if it's really necessary, okay? And then creatinine clearance. We already talked about that creatinine can be physiologically altered depending on the patient's muscle mass, age, health status, okay? So that's why creatinine is sort of an imperfect marker, which is why GFR is an estimation, because creatinine is still one of our parameters, okay? And then, again, but don't worry about this slide either all that much. I just want to tell you what it is. All right. I just showed you this one, but I feel like you need to laugh, even though you're not laughing. I know. This is the important thing. Show it. All right. What questions do you have? I'm going to slip down to some review questions for you all so we can do that. Any questions? Yes, sir.
Kidneys are important, right? And
Theoretically.
if you feel so inclined to donate a kidney, you're not working with half of what you have. It's not exactly 50% production rate. How does the lack of a kidney influence everything that we've talked about? How significant is it to donate a kidney? Does that make sense?
The remaining kidney can pick up most of the slack. So your patient's not going to be at a increased risk for any like specific disease or increased risk of dehydration or anything like that. It picks up the slack very well. The problem is the real trouble becomes that patient only now has one kidney, so you have to be a lot more careful with that health of that kidney. So that following their GFR, BU and creatinine, follow it very closely because you have to check for even the slightest decline. Because if their one kidney starts to go, then they're going to find themselves on the kidney transplant list. You know what I mean? So health-wise, you can live an essentially normal life with a single kidney, but you have to be real careful with that one you got. You know what I mean? Yes. So yeah.
I hope I asked this correctly, but the interstitial space, like in the loop of Henle, like kind of drives. It has that low osmolarity, like or high osmolarity outside of the loop of Henle. Is that what's driving the stuff coming out of the descending?
That's what's driving most of the water reabsorption. Yeah.
Okay. Mm-hmm. And is it like a specialized cell that sits in there that's allowing? Like, I'm just curious as to like, why is it low? Is it kind of like a chicken and the egg question? Is it because
why is osmolarity? It should be high. The osmolarity should be high.
But is it high because of stuff coming out of the loop of Henle, or is it already high just naturally? That's like how it just.
The vasa recta, the area down there in the renal medulla around the vasa recta from those long juxtamedullary cells is usually a high osmolality and a low oxygen environment. So I don't have a good answer for you why it's always a higher gradient there. I think most of the time it's like somebody asked me whether those long juxtamedullary nephrons go down deep into the medulla. It assists with further like concentration of the filtrate. You know what I mean? So why is that? I mean, I don't know enough renal physiology to tell you why it's like that there. I'm not going to lie. But I can look up for you if you like.
I was just curious.
That's one of those things that I was just like, cool, and I just move on. You know
I'm just curious if it was like a result of stuff moving out.
It is a
kind of like a vicious cycle to keep it high.
It is, but then theoretically that the PCT should have a much higher gradient because that's where most of the stuff is absorbed.
Right.
So again, that's what like. I can't think of a good. I don't know why the answer to that question. Honestly, no. Yes.
You said if serum creatinine levels were increased, then that would be a sign of kidney failure.
Kidney failing, not necessarily kidney failure, but yeah, acute renal injury of some kind. Yeah.
Would like creatine supplementation?
Creatine supplementation can affect serum creatinine. But not to that effect if you're just taking it like as direct. You have to be taking a lot of creatinine in order to really move that number significantly. You move it by decimal places maybe, but I'm not. When I talk about significant increase, I'm talking about doubling your creatinine or more. Up that like that. If you start to see your creatinine go 1.2, 1.4, 1.5, something's going on. But if you start to see like 2, 2.5, so on, then you're like, okay, something's going on with this person's kidney for real. Yeah.
Does like high sustained stress impact creatinine output in the
High sustained stress?
Yeah, obviously if you're
I mean, if you were like in a significant physical stress, theoretically, I suppose. But I mean, if you're like, you're talking about in relation to the stress reaction that we talked about. I suppose if it is a severe sustained stressor that becomes I'm going to say yes. Yeah. You can have an increased muscle catabolism for sure, which would then lead to increased creatinine. Not necessarily increased creatinine in the urine, which is a mechanism that should help get rid of it, but I think you might start to actually physically accumulate, and that might actually lead to kidney disease that we were talking about. So yeah. Anybody else? All right. Now I have a question for you. Vasoconstriction of the efferent arteriole. Which one of these things that you think would happen?
C.
Huh?
C.
Charlie, good. And why?
That's the right one.
Right. Well, we know that the constriction of the efferent arteriole is going to create a back pressure in the glomerulus, which means we're going to increase glomerular filtration rate, right? But it's also going to reduce the amount of blood that's able to flow out, so renal blood flow is going to go down. Very good.
E.
Increased GFR. So if stuff is flowing through too fast.
Macula what?
Macula densa cells. What are they going to secrete? You guys remember? Huh? Adenosine. Okay.
Close.
What does adenosine cause again?
What does adenosine cause?
What is in the last one in that?
Vasoconstriction.
That's
Right?
not tricky.
Because all right, I'll give you the next question. Because a reduction, which one does this cause? Remember? What causes vasodilation?
Nitric oxide.
There you go. So the inverse, right?
Yep.
Okay. Which is not an accident. We're not in the mood for a not question today, are we? I'll just give you this. It doesn't cause more water to be secreted to offload volume, right? Because what is angiotensin II doing? Trying to increase and preserve volume, so it's not gonna lead us to get rid of water. All right. So I'll save you that one for today because we feel like it smells smoke. So B has to do with which one? Base excess, right? So will we secrete hydrogen if we have base excess?
No.
No, we need to hold on to hydrogen. Would we need more bicarb? No. Would it have anything to do with urea, really? No.
Can you explain that again, sir? Because I know you talked about in the cell, something causes potassium to be kicked out. How does that
Secretion of potassium. So if we're in a base excess, we're trying to get rid of potassium so that hydrogen doesn't make its way into the cell, basically. Like, just think about it that way. Because you switch hydrogen and potassium depending on your acid-base count. So if you're in acid excess, you try to move hydrogen into the cell. So in this case, we're going to get rid of potassium so that doesn't happen. So hydrogen stays out of the cell. And then where are aquaporin 2 channels located? Last one. I know that was a lot. I know it was. So, but now we have several days. We have tomorrow. You guys can ask me questions tomorrow, and then I will be available for the whole weekend, right? All 4 days. If you need any, if you have questions, send them, like you have been. Hopefully I did my best to try to make this as straightforward as possible. This is not by any means a straightforward topic. So it's good that we have some extra days to think about it. Yes, sir. 160? Probably. Mm-hmm.
Should we add
Which, let's see.
No, with
so
No, because I'm not going to ask you about potassium. All right. Do you guys want the truth or not? Yeah, if you want to add it and have another thing to study, go ahead. But no, I'm not going to add that. I'm not going to ask you about that. So, no, you don't have to. What? Huh? If you guys think I do that to you, then go ahead, write it down. If you like, go ahead. Yeah, a micro trap. Everything's important, man. So,
Anything else?
no, you don't have, I'm being serious. Yes.